Hello guys, today we're gonna discuss about chronic pancreatitis. If you are new to this channel, please subscribe. So, chronic pancreatitis is a progressive inflammation in which there is irreversible destruction of pancreatic tissue. The most important point here is irreversible. Is in acute pancreatitis, the changes are reversible. So let's talk about the causes of chronic pancreatitis. The most common cause is alcohol consumption. Next to it is stones in the lower part of the common bile duct. Acute pancreatitis can be a sequel to chronic pancreatitis. Autoimmune pancreatitis can be another cause, and there can be mutation in the CFTR gene causing atypical CF. Hereditary pancreatitis can be another cause, and last but not the least, cystic fibrosis. But the most important thing to remember is alcohol consumption. That is the most important cause here. Cystic fibrosis is the disease that causes viscid secretions of the pancreatic enzymes. This is a pancreas. So we are gonna talk about the pathology of chronic pancreatitis. The first pathology is strictures. Strictures or a single stricture is always present in the pancreatic duct. These are the acini, and the acini undergo fibrosis. So there is irreversible replacement of acinar cells, resulting into loss of exocrine function gradually. These are islets of Langerhans, which are responsible for endocrine function. They also lost their function gradually. So these are the strictures, and beyond the strictures, a dilation is formed, which giving appearance as chain of lakes in ERCP. Sometimes there can be a stricture on the lower part of the common bile duct, resulting into obstructive jaundice. So let's talk about clinical picture. So we know there is pancreatic inflammation happening, which will result into peritoneal inflammation. Thus, it will cause epigastric pain radiating to the back because of pancreas, and there is mild tenderness because pancreas lies in the retroperitoneal region, far away from the sensitive peritoneum, parietal peritoneum, and the nature of the pain is dull aching. So the enzymes act on the fatty foods for the digestion. When this is not happening, there is malabsorption. Thus, the fat will go into the stool, causing steatorrhea. The stool becomes greasy and foul smelling, and there is pain. The patient do not want to eat. Thus, there is loss of weight and weakness in the patient. The destruction of the pancreas can result into diabetes mellitus due to widespread destruction of beta cells. It can also present as sting of jaundice. So epigastric pain, malabsorption causing steatorrhea and loss of weight and weakness, diabetes mellitus, and the sting of jaundice are the clinical picture of chronic pancreatitis. Talking about investigations, let's talk about labs. There is no specific, there is no lab test which is specific for chronic pancreatitis. There is one popular test called Lund test. Here we insert a tube which has two lumen, one towards the duodenum and one in the stomach. This is and we insert food into the stomach through the opening that goes towards the stomach, and thus we give the patient metoclopramide in order to induce stimulation of contents that is inside the stomach to the duodenum, and thus in response of the food pancreatic enzymes are secreted, and pancreatic juice is available now. So this juice, we take a sample of this juice through this duodenal opening. This is what Lund test is. So in chronic pancreatitis, secretin and pancreaticogymin stimulation, there is decreased secretion. On the sampling that we take, the secretion is decreased. Another investigation we do is glucose tolerance test for diabetes. We can measure fecal fat excretion for steatorrhea. We can do serum bilirubin and other liver function tests for obstructive jaundice. Imagine. Let's start with plain X-ray. We can see calcification or stones on plain X-ray. Ultrasound and CT is very important. Pancreatic enlargement and associated biliary pathology will be shown. This is a CT scan in a patient with chronic pancreatitis, and there is a stone obstructing the main pancreatic duct in the body of the gland with marked dilation of the duct distal to the stone. I think probably this is what it is. So this is an axial CT showing multiple calcification in the pancreas in a patient with chronic pancreatitis. You can see here multiple calcifications very clearly. With chronic pancreatitis, and you should always know that in any pancreatic pathology, CT is very much important and necessary. There is no pancreas without a CT. Another investigation we can perform is ERCP, that is endoscopic retrograde cholangiopancreatography. It is performed for surgical planning before the operation. So these are we can see the strictures, cysts, and the dilations. The dilations and strictures which resemble a chain of legs in ERCP. So this is the typical appearance in ERCP. MRCP can be performed. MRCP is magnetic resonance pancreatography. Cholangiopancreatography, there is a mistake. It's cholangiopancreatography is same to that of ERCP. So here we have a typical chain of legs appearance over here. This is MRCP. The upper figure we have is ERCP, which shows chain of legs, And the lower figure is a magnetic resonance cholangiopancreatography in a patient with chronic pancreatitis. You can see here there is a structure of the pancreatic duct pointed by the arrow, and distal to it there is dilation. This is a structure and this is the dilation. Endoscopic ultrasonography can be performed. It is the best test for imaging the pancreas, but need highly skilled gastroenterologist. Treatment. Talking about treatment, medical treatment is used for most of the cases. Number one is treatment for alcohol addiction by rehab or counseling. This is the most important one. So let's treat symptoms now. The first symptom is pain, so let's manage the pain. The approach should be stepwise, and we should use non-opiate analgesics in order to avoid erection. Malabsorption correction is done by enzyme supplement with the meal and by low fat diet with oral supplements of fat soluble vitamins. Now diabetes is another clinical picture, so insulin therapy is given for diabetes. So let's move on to surgical treatment. It is done for associated pseudocyst, ascites, fistula or fixed obstruction, and it is also done for persistent uncontrolled pain. So for the associated pseudocyst, we can perform internal drainage within the stomach, and for the persistent uncontrolled pain we can perform celiac block. Whereas there is something called fixed obstruction, we can remove the obstruction by the surgery. So the resection and drainage is done. This is the typical thing in the pancreatic surgery: resect and make a drainage. So if there is a mass in the head of pancreas, that is a disease in the head of pancreas, we do resection of head, preserving the duodenum. This is known as pancreaticoduodenostomy. Here this is stomach with the duodenum, and we remove the head. And this is the joining of the duodenum with the pancreatic duct coming through the tail of the pancreas. So if there is mass in the head of the pancreas, but if there is dilated lobes, what we can do is we can bring the duodenum in here and perform rocks in Y surgery, making a Y. This is known as pancreaticoduodenostomy. If the disease is limited to the tail, we can perform distal pancreatectomy. So I have already told you celiac block is used to interrupt pain pathway, especially in intolerable pain. And we can perform endoscopic sphincterectomy, that is incision of the sphincter, in cases of obstruction of duct opening with stone and stenosis of duodenal papillae. Thank you for watching this video. I hope you enjoyed it. Don't forget to like, give your feedbacks and subscribe.